Okay, we'll try again. Good morning, everyone. This is the September 16th meeting of the Eastern Idaho District Board of Health. We are meeting in the conference room at the Eastern Idaho Public Health Facility, and this meeting is also being broadcast through our YouTube channel. So we welcome all the public that is in the meeting today. There will be a lot of information and some important business conducted throughout the day. We're going to begin with a roll call, and I think we'll do that by allowing each of the board members to introduce themselves. And we'll go ahead and start with Commissioner Mendenhall. Okay, we'll go ahead and start with Commissioner Mendenhall. Make sure to turn your mic on.
Commissioner Mendenhall, Madison County. Shane Ryan, Jefferson County.
Bill Lake, the Teton County Representative.
Greg Shannon, Clark County Commissioner. Blair Dance, Commissioner, Fremont County.
Leah Masson, Commissioner.
All right, thank you. We are absent one board member today, Commissioner Wayne Butts from Custer County. We do have quorum. We appreciate everyone being with us today.
And Commissioner Butts did give his proxy to Commissioner Shannon.
Oh, that's right. Okay, so there is a proxy with Commissioner Shannon for Commissioner Butts. So thank you. We'll go ahead and move to our approval of our consent agenda. Those are the fiscal year 22 year-to-date financial report, as well as approval of the August 20th minutes. They were sent out to everybody. They are on our website. Are there any questions about those? If not, I'll entertain a motion to approve.
Sure. This is Commissioner Shannon.
Okay. Is there a second?
Commissioner Masson.
Okay. Second from Commissioner Matson. Any discussion? If not, all in favor, say aye.
Aye.
Anyone opposed?
Mr. Chairman, may I ask, we're hearing reports of having a hard time hearing, so I need you to put the microphone right near your mouth and speak very loudly, please.
Okay. Sounds like there is some audio challenges today, so please everyone speak up. So we'll go ahead and move into our item number 3, our COVID-19 situational report. Before we do, I need to make an announcement. Unfortunately, the decision was made last night to move the entire state into a statewide crisis standard of care. That decision was made after consultation with all the hospitals across the state. It is my understanding that St. Luke's made the request late yesterday to Director Jepson. He then, in consultation with other hospitals throughout the state, including here in Eastern Idaho, made the determination to make it a statewide decision. So it is unfortunate because everything that we've worked all year for now seems to have happened. And that's that in Idaho, we went to a statewide crisis standard of care. We are going to get information today to help us understand exactly what that means and to be able to ask questions of the hospitals, but also of Dr. Krell, who sits on that committee. Help me understand that committee, Chair.
Yeah, there's a statewide CIDMAC, Disaster Activation Committee, that has developed this crisis standards of care for Idaho. That committee did meet yesterday, but then there's also a separate activation committee, and Dr. Ken Krell from our area does sit on that committee.
So we'll be getting a report from him later today to help us understand the whole ramifications of that. it just shows the, the situation that we're in right now. So we'll go ahead and move to a vaccine update by our Clinical Services Director, Amy Campbell. Good morning, welcome.
This morning, I'm not going to do a formal go through the vaccine information, but I did want to remind everybody that you can access that data anytime at the state's webpage, the coronavirus site. I did look this morning, and they are reporting 50.4% of 12 weeks up to date. This compares with 63% nationally, and all along we get lower than the national rate, so no surprise there. Also reported is 89.1% of cases are still in unvaccinated individuals. We'll talk about, we're also reporting that for our health district on our webpage as well. And so again, both of that, all that information is available for you to look at. Eastern Public Health, we continue to offer vaccine clinics at least once a week in every county, from our small counties to our large county. We were able to get some vaccine this week. And so we also are offering all 3 presentations at all of those clinics. And so any vaccine that anybody's requested, we're able to provide that vaccination in all of the counties. And then I guess the big news this week will be that there's going to be a recommendation for booster doses, and that meeting is tomorrow with the FDA subcommittee. And that starts at 6:30 in the morning, so I'll be up and eagerly awaiting that. If that is approved, then we're setting up a place this weekend to be able to roll with those doses on Monday if that recommendation comes. If it does not come, then it's postponing that until we'll be ready to go with them. That's all I have. Any questions for me?
Any questions? Okay, thank you for all that you're doing. We appreciate you being here. So we'll next move to a COVID-19 data review by our epidemiologist, James Morgan.
And certainly this will probably be less of a data review than we did last time. I was only where we did a pretty exhaustive extent of our data last time. This time it really is just an awareness that the numbers are increasing across district and across most counties. So our rates are still posted. We continue to fine tune the data on our website and dashboard that reflect as much as possible what we're seeing and what information that we can present. So information is there and available for individuals. We're continuing to increase our ability to do disease investigations as cases continue to rise, more individuals hired. But again, cases continue to increase, and we'll continue to do disease investigation.
Any questions? James? I have one. I know that you track in your data the hospitalization or the cases unvaccinated versus vaccinated. How is that running now? Are we still seeing a strong effect from the vaccine?
Yeah, specifically within the hospitalization as well. So yeah, on our dashboard, we do have a hospitalization and vaccine rate group tab that we showed kind of last time. That number changes day by day as individuals are currently hospitalized, vaccinated versus unvaccinated. And it's run anywhere from 78 to 98% of individuals are unvaccinated that are hospitalized. So again, that number is displayed on the vaccine rate through hospitalization. So it's there.
Okay, thank you. Are there other questions? All right, thank you, James. it appears we're having some audio difficulties, so we are working on that at this time.
Test. You functioning now?
We have been having some audio difficulties, but it appears that we are near ready to begin again. We good? Okay, thank you. There are certainly some challenges to be able to do a meeting both live and broadcast on YouTube. And we appreciate our director and all the staff and the IT staff at Eastern Iowa Public Health for the efforts that they make to be able to do this. We do it for the purpose of allowing as much public as possible to be able to receive the information at the meeting and to be able to attend. And so again, our thanks, and we're hopeful that everyone is able to hear now. We did move through the beginning of our agenda quite rapidly.
we've had an update of our vaccine as well as our current situation. And we wanted to save as much time as possible to be able to discuss where we're at with our hospitals and with the crisis standards of care now implemented throughout the state. But as we do that, if we need to circle back to Amy or to James and get more information, we can certainly do that. So with that said, I believe that we have Dr. Rachel Gonzalez on the line from Madison Hospital, and we appreciate you being with us. Can you hear me all right?
I can.
Okay, well, thank you for being here with us and giving us this report.
Morning, everybody. So we do have Casey on. I'm giving the report today. We thought it would be helpful if we provided one of us who kind of gives the status and the update report. And then David is also on the phone listening. And so we're all here to try to answer some questions. And certainly Dr. Krell can color in some lines as well as the crisis standards of care. I'm going to give some detail of where our 3 hospitals are so that you can have some statistics to get a feel for it. But I would love to emphasize that this really, where the hospitals are today, is really not just about COVID. It's, for example, IRMAC currently has 41 COVID inpatients of their 259. We have 4 here today. Idaho Falls Community Hospital has 23 COVID inpatients. 7 of them are in the ICU, or 7 are in the ICU, and that expands their capacity by 1. So hearing those numbers and compared to last year, we may go, well, that's manageable. You've been able to do that. But the reality is every hospital is having significant staffing issues. And this isn't related to all of our staff being out due to COVID. Now, certainly we have some at different facilities, and that varies, that are out for COVID or other things. But the staffing crisis has become significant, and it isn't just our clinical areas, it is our support areas as well. And all of our EDs are very busy with a lot of respiratory. And I think this is, and again, Dr. Krell, I'm kind of setting it up for you a bit. This is across the state that you see this. And we learned that we need to care for all patients, and we need to be here for all patients. And what's happening in the other sides of the state that's quite concerning is when you have the rapid increase in the COVID patients or these other type of respiratory illnesses, we still have a lot of other patients that desperately need health care. And so I'll give you a little detail, and then certainly I think we can kind of tag team this and have a little more conversation after Dr. Krell reports on this. But if you think about our total census from a hospital, not just the COVID census, IRMAC is up 42% in their hospital capacity compared to last year, and that's their average daily census. That's a significant increase. And again, it's great that we're here for these patients, but you have to remember, we talked about this in the past, that most hospitals in the country have not had a staffing pattern where we staff to complete full capacity. It isn't historically been our models. And now many of us are past any of those capacities, not just from a bed standpoint, but certainly from a staffing standpoint. We're up 23%. Every emergency room at different times is boarding patients in their emergency rooms. And some of this is normal business, but it's kind of a, hour by hour, day by day type of situation. And so it is, concerning to see our numbers in a specific disease go up because it impacts our total ability to provide healthcare. I think just a couple more stats, and then I really want Dr. Krell to chime in and then let us answer any questions you have to help understand the situation. Right now, Idaho Falls Community Hospital, actually this was within the last hour, so it could have changed. But ERMAC had 2 beds available in their pediatric PICU. They're at full capacity, essentially. Idaho Falls Community Hospital has room for 4 patients. And we can take 3 to 5, depending on the acuity here today. And again, you know, we've probably got right now 6 open rooms, but we're able to staff 3 to 5 more patients, depending on that acuity of those patients. So Dr. Krell, I think, you know, and I can color in with more stats, but I hope that kind of starts the conversation. So I'll turn it over to you, sir.
Okay, so before we do that, Dr. Krell, are there any questions for Dr. Gonzalez as far as on her report and where the hospitals are sitting? Okay, so we are glad to welcome Dr. Krell. You do sit on that statewide Crisis Standards of Care Committee, and I know that you've been very active on that, and particularly working hard yesterday as this all came about. So Dr. Krell, we'll go ahead and turn some time to you for your report.
Yeah, this is a very sad day for us. Having to move to statewide crisis standards was not a situation any of us had ever hoped we would be in. The request yesterday specifically was from districts 4 crisis standards applied to districts 3, 4, and 5. We discussed the situation. I emphasized that we are in much the same situation in Eastern Idaho. And today, for instance, I have 2 patients boarding in the emergency room, ICU patients. We have a number of medical patients boarding in the ICU, boarding in the ER. There are literally no physical beds to place patients. We have sometimes been in the position recently of opening up space in our PACU, our post-surgical unit, and in our infusion center for ICU patients. But to some extent, it doesn't matter how much space we open up when we don't have staff to take care of them. And that's the situation statewide, is our inability to fully staff. That then did prompt us yesterday to make a recommendation to Mr. Jepson, to the Department of Health and Welfare Director, for statewide activation of crisis standards. And as you know, he announced that this morning. I've been reluctant, and so have other clinicians, to make that recommendation, but we really are at the point where we have no choice. The reason is that we need to have a sensible algorithm for deciding who gets what level of care, a triage system, both within the hospital for deciding who gets what level of care, and in deciding what patients get accepted from outside hospitals. For instance, we have, it has been gut-wrenching for us over these last several weeks to not be able to provide support to our critical access and smaller hospitals in accepting patients from those hospitals who they don't have the capability of caring for. But because of our load, we have not been able to take patients. We have continued to take all trauma and heart attacks and strokes, what we've called those time-limited emergencies. And frankly, some of that's going to have to change under crisis standards so that we can start to triage patients who have a reasonable probability of survival and provide care rationally. Crisis standards of care is based on 2 criteria that we developed over the last year. The first is to save the most lives. And to accomplish that, we use a scoring system. And I must say it's rather morbid to put people on a scoring system and decide who's most likely to survive. We use what's called a SOFA system, and that looks at their organ function and their acute illness. So the scoring system decides who is most likely to survive, who has the least points, and so is the least ill and so likely to get through their acute hospitalization. The second principle then is save the most life years. And what that means is that you consider in the decision of who gets triaged to care by the probability that they're going to survive not just this acute illness, but over some period of time. That is, what medical comorbidities do they have? What other chronic illnesses that would affect their survival? Secondly, we never want to call it age because we want to be careful there's no discrimination. But for a young patient who has not lived through their life cycles would have an advantage over an older individual like myself who has been through their life cycles, if you will. So with those two criteria, then you come up with a scoring system. This is only going to be applied if we have a limit on resources in which we can't provide both those patients sitting in front of us with a level of care that would be expected. It applies, for instance, on who gets ventilators, who gets dialysis, who get other services, but realistically, it's coming down to who gets a nurse, who gets a respiratory therapist, because we are so limited in those resources. And as stretched as we are beyond a certain point, then all patient care gets compromised. And so we've got to make logical decisions about who gets care. That's the grim reality of operating under crisis standards of care. Now, we're hopeful that we're not going to be in a position, for instance, of deciding that somebody sitting in the emergency room has a better probability of survival and we can save more life years by taking a patient off a ventilator, for instance, who's on one. Kootenai, where crisis was first initiated, has avoided that to this point. It is possible if things continue to accelerate that that's the position we're going to be in. The other point I'd make is that what worries us all as clinicians about instituting crisis standards of care is that we'll see a return to what we had last winter, which is patients were avoiding necessary acute care because they were either frightened of hospitals or thought that the hospital simply couldn't take care of them. We do want to emphasize that for patients who are acutely ill, that we would encourage you not to avoid care. We'll triage you. We'll take care of things as best we can. We need patience in terms of patients waiting in the ER for extended period of time, but we do not want to see what we saw last winter, which was additional deaths unrelated to COVID because of people avoiding medical encounters because they were either afraid of hospitals or thought they weren't going to be able to get care. And that's our fear here. The other is that we don't want to create panic across the state. We believe by instituting this, we can do our best at being fair and humane about provision of services. I don't like using the word rationing. We believe it's a humane algorithm, if you will, that allows us to provide care to those who are most likely to need the specialized services and to provide always comfort and care to all patients as best our ability. But it is so important to understand that we have never been in this position. I've been doing this for, maybe 40 years. We've never seen anything like this. One of the hospitals north described yesterday calling 87 hospitals to get a patient referred out of northern Idaho. We believe that this system is going to allow us better coordination within the state, and for our hospital, the region, because as you know, we care for a lot of patients from Wyoming and Montana, to allow us to make better decisions about who should be transferred in and what patients can be handled at a lower not lower capability, but at a critical access hospital that doesn't have the kind of resources that we have. Jerry asked me to speak a little bit about those topics, and that was quite brief. I want to be able to answer any questions you've got, or if you have further topics you'd like us to speak about.
Okay, thank you, Dr. Krell. Are there questions from the board for the doctor? Yes, Commissioner Dance.
Doctor, could you speak to the situation of the surrounding states, our neighboring states?
Yeah, the two that we're most familiar with are Utah and Washington. As you probably have heard, Spokane is very rarely able to take patients from northern Idaho because Washington, as you know, has also been in a surge of cases. Likewise, we've seen cases increasing in Utah, and frankly, we've predominantly stopped calling Utah hospitals because they have not been in a position to be able to take patients for quite some time. That taking care of their own population and some from Wyoming has been overwhelming for them as well. So we really aren't getting help from out of state.
Okay, thank you. Dr. Gonzalez, did you have a question?
I wanted to add one piece to what Dr. Krell had presented on. I absolutely want to reemphasize the coordination that the hospitals across the state are doing to provide great care. I would do a little shout out for all of the healthcare workers right now. There are times in some of the hospitals that there are frustrations from the public when they come in. And I would just ask everybody to show a little love and compassion to everyone. I know Dr. Krell, for example, is doing absolutely everything he can to provide the best care to every person that he sees, as with every other provider. And at times, there's stressful situations and we see some of those interactions with the public. And I would just do a quick little shout out and thank you to Dr. Krell and every single provider and clinician during these hard times, and ask the public to help us with that.
All right, thank you very much. And I would certainly echo that, the appreciation that we have for them. Dr. Krell, help me understand this, or Dr. Gonzalez. I'm assuming that part of the problem with staffing right now is just the burnout. I mean, I'm sure that they are overwhelmed, and I'm sure a year from now they were all doing overtime shifts and just putting in every ounce that they can, but people can only do that for so long. Is that what you're seeing, or are there other issues that are causing the lack of staffing?
There are several components to that. Quite clearly, a major component has been that we're all tired, and I just ache for our nurses and our therapists and all of our other staff. I mean, we are so short-staffed, for instance, in the cafeteria. We're short in laundry services and housekeepers that with the over 40% increase in patient load from a year ago, About a third of that increase for us are COVID. About a third of our total patients may be COVID patients, for instance, in the ICU. So it is the combination of not just COVID here, although that's more so in the Treasure Valley, but also just the increase in total number of patients to provide care for the region in trauma patients, other medically ill patients, children with RSV now, and those medical and surgical emergencies and trauma that we're responsible for taking care of. So the staff is very overwhelmed. Some of it has been that a number of healthcare workers have just gotten frustrated and left the field. We've seen that both in physicians and nurses and respiratory therapists, that the difficulty under these circumstances, the frustration, for instance, knowing that we could be out of this, that none of this was necessary. And then increasingly, we're dealing with a portion of the population who will come in with COVID critically ill and still deny that it even exists, let alone that they would consider getting a vaccine. And that has been particularly difficult. I ache for our staff who are working many more shifts than they're used to, who are handling many more patients than they're used to. We're using a model often now called team nursing, where we take one ICU nurse and pair him or her with a nurse who is not a critically trained nurse, and then give them 4 patients, where normally an ICU nurse would not have more than 2, often 1. But we don't have the resources. And so our staff is not just working much longer hours, they're working much, much harder and under limited resources.
All right, thank you. Are there other questions from board members? One other question that I might have, Dr. Krell, is what you are seeing as far as the efficacy of the vaccine. We had a report from James Corbett this morning that it varies, but 75 to 90% of the patients in the hospital are unvaccinated. Does that hold true to what you're seeing? Certainly it does. And can you help us understand that you said that this wasn't necessary? How can we get out of this? How could have this been avoided?
Probably, I don't know that we actually have very accurate statistics, because frankly, we find hostility if we ask patients or families whether they or their loved one has been vaccinated, and we don't want to be adversarial. But probably somewhere in the neighborhood of 90% of cases requiring hospitalization for us are unvaccinated. There are a few patients who have been vaccinated and required hospitalization, but I believe our statistics probably run like the national statistics, that it is exceedingly uncommon to get sick enough with the Delta variant to require hospitalization, and certainly risk of death is decreased by mid to high 90s with the vaccine. And of course, that's some of our frustration, that we didn't have to get to this place if people would get vaccinated. So we do occasionally see a patient who's unvaccinated or who has been vaccinated and require hospitalization. And those have been often patients who are immunosuppressed, who we know did not get, weren't as likely to get as good an antibody response to the vaccine as somebody who is not immunocompromised. It is likely the case that we are going to see some waning of antibody levels. and thus some increased risk for infection, although not necessarily clear at this point that that's an increased risk for severe illness or death. But that's where the discussion is coming in terms of booster vaccines. And much of that will be to just decrease the total community load out there. We believe at this point that the protection with the Moderna and Pfizer from 2 doses is holding up very well for severe illness and death and hospitalization. The efficacy is waning for just getting infection. And that's where I think you're going to see booster vaccines be useful. But the real message is that to the public is that we need to protect each other, we need to protect ourselves, we need to protect our loved ones in our community, and that the vaccine efficacy is just so much better than what we ever could have prayed for. That we all need to be cognizant of the fact that despite all the misinformation, despite my anger at someone like Cole from Boise out there spreading misinformation and costing lives, that the data is clear from reliable sources that the efficacy of the vaccine for making you very sick or dying is holding up very well. And the safety of the vaccine is virtually unprecedented for vaccines.
Thank you. Other questions? Jerry, do you have any questions?
Jerry?
I don't know if hospital representatives want to.
Got to hear you. There.
I don't know if any of the hospital representatives want to comment on this, but for going on 3 weeks, there has been a daily call with all hospitals across the state, taking an assessment and identifying what capacity that they have to assist hospitals that are needing to transfer patients. So I just want everyone to know that the hospitals have been collaborating as closely as they can to try to get the best care for patients across our state.
Yeah, I might comment on that briefly. There's a daily, what's called mock call with all of the hospitals, virtually all of the hospitals, looking at available resources, seeing if hospitals have patients they can't accommodate, who can take them. We had a SIDMAC meeting yesterday, the State of Idaho Disaster Medical Advisory Committee, which we wrote the crisis standards of care. And talked about now if we are statewide on crisis standards, that we can better coordinate across the state those resources for transferring from one hospital to another. It's not an easy process because those resources change certainly from hour to hour and often from minute to minute. But looking at other means of coordination, now that we're all on statewide crisis standards, we're looking at how we can more efficiently do that and do that on a real-time basis. The mock calls have been, to this point, the means of coordination, and we're just looking at what we can do to do that in more real time.
If I may, I would just add that we have the state opened up an app for us to be able to use. So we've got multiple mechanisms to be able to coordinate across the state. I've heard a lot of things from not just transferring patients and coordination. We're certainly sharing different, equipment across the state, helping in lots of different ways. So I believe that if you saw the inner workings of all of that, you would be very proud to know that the entire community, hospital community, is working together on that. And appreciating the state opening up the apps and the different things and mechanisms to help us with that.
All right, thank you. Seeing no other questions, just to kind of conclude this, Um, Again, our appreciation goes out to all of you in the medical community and everything that you're doing. I know that you're overwhelmed, and I know that you're doing everything, and I know that you have been doing it for a long time. And so our thanks to you. But just as a final message, what can the community do to best help with this crisis? I mean, what can people in the community do to help with this hospital situation now?
The two critical areas are masking and vaccines. Without getting a higher percentage of the community vaccinated, we are going to be in this crisis for a much longer period of time. It does appear, for instance, from the data from India, that eventually with Delta, caseloads will fall even without vaccines. But that's going to be thousands and thousands of lost lives and a healthcare system that's completely overwhelmed. The most important message we can all relay to our colleagues, our coworkers, our family, our friends, is the absolute vital necessity of getting vaccinated to protect yourself and your family and the community. The other is that while we have this load of virus in the community, that unfortunately masking is still important in terms of preventing person-to-person spread. And so I think we've got to consider, for instance, in gatherings, particularly indoors, and particularly when social distancing, physical distancing is not possible, that we still need to be adherent to the recommendations on masking. But our ticket out of this is going to be vaccines, and it's so discouraging to us to watch how very slowly within the state vaccine rates are increasing, and the hostility and the misinformation out there that for some reason some members of the public find easier to accept than the scientific data. So our plea would be to those of us who are vaccinated, please spread that message. And to those of you who aren't vaccinated, consider the patient I intubated yesterday who said, well, I decided I was going to get a vaccine maybe sometime in October. We don't have time to wait. Please get vaccinated as soon as possible if you haven't been.
All right. Thank you, Dr. Krell and Dr. Gonzalez. We really appreciate your time
May
this
I add
morning.
one piece?
Of course.
I agree completely with everything that Dr. Krell suggested. Absolutely get vaccinated and all the other suggestions. One other piece is please continue to access healthcare and go to the hospital when you need to go to the hospital. But if you believe that you can go to your primary care offices, the urgent cares as well, please do that if you feel that's appropriate. We're here for you, and so are your physician offices. So seek, your shots through the outpatient pharmacies, those areas. So access the different levels of healthcare and come to the ER and the hospital when you need our level of help.
All right. Thank you. Thank you very much for being here. And we wish you well. And we hope that your message resonates in the communities and that it does help people understand how we get back out of this. So thank you. With that, we have just about 5 or 10 minutes before we'll begin our interviews for our physician for the board. Are there other questions for James or Amy? I know we had a very short report from them because we wanted to save as much time as possible for Dr. Krell and Dr. Gonzalez. Any other questions or anything else that either one of you would like to add?
Mr. Chairman, I was just wondering what the flu season.
Yeah, good question, Commissioner Shanton. two.
So yeah, influenza, typically we don't see the peak until February when you look at the last more. Can you hear me now? Typically when you see influenza, it peaks in February. So yeah, I'm interested to see how that normally goes. And that goes back, I think the last 38 years. I actually was just on a conference call. And so I don't know what that looks like, but we definitely are seeing, and the hospital staff could probably report that as well, seeing more respiratory illnesses in general. Talked to a physician the other day that's seeing lots of RSV cases, for example, in young population. And I'm sure that's having impacts on those hospitals as well. And I'm sure Rachel could add to that.
Yeah, it's unusual to just see RSV at this time of year, honestly, and the level that we're seeing it. And on influenza, just to be 100% clear, and you can certainly speak to this, your COVID vaccine is very different than your influenza vaccine. So please get them both. And we think that's, second knowledge for us, but they really are very different vaccinations. And we hope that you get them both and, protect those little kiddos with RSV. It's something that's just a simple cold for us, but for the kiddos, it, requires sometimes sending them to primary children's.
Amy, can you help us and the community understand where we're at on the boosters? I know there's a lot of question with that.
There's a lot of questions nationally and worldwide as well. And so as you've seen reported, vaccine still is doing a great job at covering very well. I mean, we're still seeing breakthrough cases, but more people that are unvaccinated are getting COVID. And so I think some of that controversy comes, should we be focusing on individuals that aren't vaccinated at all? Or now looking at some of those breakthrough cases and how a booster dose could reduce some of that. And so, yeah, when the FDA meets tomorrow, they'll have the data and I'll have a better answer on that. But I mean, they're taking the time to look through that data and make sure they make the right decision too.
Okay, thank you. Any other questions from the board?
Do you have that in a percentage, James? Reinfection rate.
So the question just kind of is reinfections and what's the hospitalization rate? Is that what you're, so it's really difficult to tell. Many times we do not get reinfection data because people don't get tested a second time, or they didn't get tested the first time. So it's been a number that's been very elusive to us. And as you heard Dr. Krell report, many individuals don't necessarily even report it to the providers as they're coming into the hospital. So that number has been more elusive than the vaccine, which we can kind of show with, data that we've given them something. Reinfection has not always been easy to obtain due to those reasons that we just talked about. If I may too, one other thing that just to echo what Dr. Gonzalez mentioned there with RSV and influenza, it just reemphasizes the point that regardless of your illness, please stay home. Many of these illnesses can affect immunosuppressed individuals or children that are young and not protected to go into the hospitals and put us into situations, as well as be confusing to really get us out of the COVID situation. So when you're ill, please stay home. Even if if you don't think it's COVID and something, please stay home when you're ill. That will help us really achieve lower rates of all infections, and that will help us to get the hospitals out of crisis standards of care.
Okay, great. Thank you. Any other questions?
Yeah.
Yes, Commissioner Young.
I heard Dr. Krell refer to India and what they went through, the cycle they went through. And is there any kind of idea how, at the current rate of infection for us in Eastern Idaho, how long this could possibly last without people getting the vaccination? Could this last another month or 2 or 3 or 6 before we get herd immunity, as they say?
Yeah, great question. We don't have the answer because it's so new, right? We look at other countries that have been doing this, India, England, that's also had the Delta variant go through, and they did have sharp increases and then for a short time period, and then was able to, excuse me. But due to the fact that it's different for each country, and each one has slightly different vaccines at times, and they're slightly more effective versus less effective. And different time periods away from that vaccination, as you could hear Dr. Krell report and that we've reported, we're seeing slight increases in the vaccinated individuals. Their booster dose may be needed to help avoid the infections. Really what we're hoping for is vaccinated individuals stay out of the hospitals, and that's what we're seeing, and that's what we need to focus on. I can't predict a time frame of when it might be. I would have hoped it would have been 3 weeks ago or none at all, but here we are.
Okay.
Like I explained last time, I'll just, I guess, answer that. We are on the similar trajectory than we were last year as well, and we peaked, right around Thanksgiving time. So that could be an answer, and that could be a complete guess as well.
Okay,
And I'll
thank you,
just-
Commissioner Madsen.
Yes, and it may be too early to ask this question, but for the booster, because I know you're meeting tomorrow or whatnot, is there going to be another like scale of criteria levels, in regards to age, maybe emergency services, those type of things to get that booster?
Right. And that's what'll come out in the FDA meeting. Just everything I'm reading, speculation is, I bet it'll come out to a specific population initially, just like before. And the meeting for tomorrow is just for Pfizer doses. So Moderna also has to present their data. And so that initial booster, if approved, will come out for individuals that have Pfizer the first go around, and then their Pfizer booster. And that, I imagine that then that'll follow a few weeks later with the Moderna booster as well. And again, I want to reiterate, the booster doses, if approved, are going to be important, but as important also is those that are completely unvaccinated, starting that primary series and getting vaccinated as well.
Now, is there any data from like India or something? Did they do the booster shot? Is there anything that made us believe that the booster shot would be more effective?
There is, and two, I think the India and UK both, right? Are those that you're presenting tomorrow? Israel, in Israel. We were able to just get the agenda yesterday to see who is presenting at the FDA meeting. But yes, those other countries that have been administering the booster, as well as Pfizer's own studies, will all be presented tomorrow at that meeting.
Thank you.
All right, thank you. All right, thank you very much. We'll go ahead and move to the next portion of our agenda, which is the interviews for our position on the board for the physician. We are very fortunate to have so many physicians in our area that were willing to come forward and offer their services to the board. It really is an example of the service that they were willing to give. We had great applicants. We had 7 wonderful applicants. We, as a smaller committee, was able to meet with all 7 of them last week, and it was a very difficult task because they were all highly qualified, and all of them would have been a great resource for our board. But we needed to narrow it down to 1, and so to keep that process moving forward, we invited 4 back today. Before we go to them, let me just quickly review a couple of items from the Idaho statute. It's 39-411. This statute deals with the composition of a district board of health. And I'm in number 1B. districts with 8 counties or more, which is us with 8 counties. The District Board of Health shall consist of not fewer than 8 and no more than 9 members. Thus, we only have room for 1 position, is where we're at now. And then if you go to item 2, it says each member of the District Board of Health shall be a citizen of the United States, a resident of the state of Idaho, and of the public health district for at least 1 year. It goes on to say 1 member of the district board, if available to serve, shall be a physician licensed by the Idaho State Board of Medicine. And of course, as I mentioned, we're fortunate because we had several that were able and willing to serve. And then lastly, it says all members shall be chosen with due regard to their knowledge and interest in public health and in promoting the health of the citizens of the state and the public health district. So I found that was interesting, and that is what we are looking for today, and certainly they all are, and that's why they're offering their service, but we need to find the one that is just right at this time to help promote the entire message of public health. So with that, Dr. Curtis, we invite you to go ahead and take the hot seat, if you will, the place that we have for you there. Let me explain just the process a little bit. We will have about 20 or 25 minutes. We welcome you and thank you for being here with us. We enjoyed our interview with you last week and are grateful for you being here today. We are going to ask Commissioner Mendenhall to ask 3 questions that we have, and if need be, he may follow up with some additional to make sure the question is answered. But we would ask you to kind of watch the time and help us manage it so that we're done here by approximately 25 after the hour. And so Commissioner Mendenhall, turn the time to you for the questions.
Tell us about yourself and why you're interested in serving on the board.
Well, thank you and good morning. So I grew up in this area. I was born over at Riverview Hospital, and I was a Grizzly, Skyline Grizzly. I've went Temple View Elementary and Eagle Rock also. So I love this area. I love this community. On my mom's side of the family, they're all educators and homesteaders in this area. My dad and my mother is actually born in a cabin in Lorenzo. And so I've always been really close to the land and this area and the people. My dad, he grew up in Sugar City, and he was a nuclear chemist out at the site. And so they had a lot of huge influences on me. I'm the second, the youngest of 9 kids. And so I got to have a lot of experiences here throughout Idaho. Because of my brothers, essentially, I'm an avid outdoorsman. I love going up salmon and Henry's Lake and Palisades, all the areas around here. So the counties that are covered in this district are dear to my heart. I actually started out as an art major and ended up through a number of fortuitous events. I ended up becoming an EMT and then a paramedic, and I found out that I liked medicine. So I wasn't originally planning on doing medicine, but I was going to be a starving artist instead. But there is definitely an art and a science to medicine, and my life's journey has looked. It doesn't make much sense. Didn't make sense to me going forward, but looking back, it makes a lot of sense. And I love this community. I want what's my kids are here. I came back. It's God's country, and rationale for being on the board is that I have a master's in public health. I'm well situated for helping with different facets like epidemiology. Also, I know the emergency side of things, pre-hospital care, and incident command systems. And also, I'm a huge proponent of lifestyle medicine. And I'm looking at healthy communities, and I know we're all dealing with everybody's dealing with this pandemic, but as I spoke before, that 70 to 80% of what our healthcare costs are due to chronic disease. And we can prevent nearly 80% of cancers just with our lifestyle interventions. And so I think I have a lot to offer this board and this community.
That's actually a good segue to the next question. As you touched on, COVID-19 has inundated this board. With that background, there are so many other public health issues that are present. Touched on a little bit. You would take the top 3 public health priorities for experience brings to addressing.
Well, really our top 3, there's it's called a theory of unifying disease and metabolic syndrome, and I had actually one professor that combined them all together, but I'll hit on the top ones. So we have heart disease, obesity, and other senescent diseases, which are like those are senescent diseases, which means that the elderly, as we grow older, because we are growing older, those are going to be our biggest health issues. And then the final one is really addiction, mental health. Those are huge issues in this community and all throughout the United States. Those are the things that are going to cost the most money. Those are if we're going to be looking at healthcare rationing. I know we're talking about acute beds in the hospital with COVID, but it's not sustainable. Essentially, what's going on with our even middle-aged individuals and younger folks with obesity, which can lead to type 2 diabetes and all sorts of problems with metabolic syndrome and those they end up cascading to other types of diseases. And really, you can't really take care of those without taking care of the mental health of our communities, and mental health is so very important. I'm the medical director at the INL, and one of the things that my college, which is the American College of Occupational and Environmental Medicine, what we look at is we can't have safe employees without having healthy employees. And we really can't have healthy employees without having mentally well employees. And that rolls right over into the community, whether they're employed or not. They're members of our community, whether they're rural or whether they are fairly urban. It's really important. And I love seeing things in our community like the crisis center over here. I think those are things that we should continue to promote and help prevent, because there's a lot of people that are at risk and need help, whether it's with mental health issues or with their personal health issues.
We heard today report that our hospitals are stretched, staff, beds, physical facilities, all of that. And crisis standards of care, statewide. We're the physician on our board of health. We are not doctors. What would your guidance be to this board as well as the response to crisis?
Well, what I've thought about this, and it's dear to my heart, because I have a brother that actually got the Delta variant down in Vegas, and he had COVID last year, and there's a lot of misinformation out there, and he ended up needing to be intubated in August, and so this is very recent for me, and it makes it very real. And the ventilator was not working, and so we needed to do ECMO, which is extracorporeal membrane oxygenation. They were going to send him to California, no beds, nothing available. And I spoke with the chief cardiothoracic surgeon, Dr. Selsman at University of Utah. I said, Doc, I have 2 questions for you. I said, number 1, do you have an ECMO bed? Number 2, who do I talk to for a lung transplant for my brother? He said, those are easy. He said, ECMO, we have a machine, we don't have anybody to run it. The second thing, if your brother makes it, talk to me, come talk to me. I've taken 3 ethics courses throughout my career. Ethics is something very difficult, morality, and that most of the time, if you look at, those are pretty much made up by the time you're 5 years old. They're very hard things to teach. So what it takes is objectivity. And what I would recommend if we did come to a situation where we'd be rationing, the objective stance would be, it's called YPLL, years of productive life left. And that would be the way that I would recommend that other physicians, well, number 1, you'd want to involve the medical community with, not just me, with those types of rationales. But that's what I would look at, years of productive life left. And it's really difficult because you have the wage earner, and then you have the younger people, and then you have your outcomes. It's very difficult. And frankly, I'm lucky that in my career, I've had to triage. I've definitely had to triage as a paramedic and not so much as a physician, but you're talking the intensivist critical care. And a really good read is the Society for Critical Care Medicine. They recently published on autonomy and beneficence and rationale. And if it's because of an infectious disease, desperate times, desperate measures. And I'm a proponent of getting vaccinated, which is has been demonstrated to be very, very effective. And it's just a difficult dilemma with the autonomy and things, and whether we're gonna, how do you force a community? Where I'm working at, it's an executive order. But it's still difficult, and we still want to understand, and there's still people that have exemptions and things like that. But frankly, for regular mundane things, if my kid gets appendicitis and they get septic, there's somebody that had a choice. They had a choice to be vaccinated or not. And it's like, well, so my kid doesn't get to recover. It's hard. I know I'm being selfish. I'm looking at it that way, but I do look. I look at the golden rule and look at. I want to treat my patients and my neighbors as I would treat myself or my family, and that's really you have to take compassion. I don't have a good answer. Rationing is so difficult, and it's been theoretical, but we're here.
All right. Thank you, Dr. Curtis. Is there any questions you have for us, or anything that you would like to add in summation?
Well, in summation, I saw my competition, and it wouldn't hurt my feelings if one of them got chosen, because they look like very awesome individuals also, and I'm always available. I'm in the community, I'm embedded, and anytime, day or night. My deputy, he does the emergency medical services with public health and you folks, and so he's been going to those meetings. And what, besides COVID-19, what do you as a board recognize or think is the most critical, crucial element for Eastern Idaho public health? What's the biggest risk of our population?
I'll ask our director to weigh in on that. Thank you for that question, and thank you for being so gracious about the other positions that we have. And that's what we have seen, is that we are very fortunate to be able to have such wonderful candidates that are willing to serve. I believe that we're doing this process correctly, and I know that because of it, we will be really well served. The entire community will be well served by the physician that we add to our board. We have just 5 more minutes. Is there a question and follow-up that any of the board members would have? Yes, Bill Lake.
I'm Bill Lake from Teton County. I guess I'd follow up with this year, the funding for the public health district. Between the 7 across the state, we got a little over $10 million or so. We divided it up. That funding has gone away, and now it's been put on the counties to come up with that money. In our case, it's about $1.2 million across the 8 counties. So I think our biggest challenge in the future, seeing wherever county is, that the counties don't have any extra money. I mean, the counties have lots of responsibilities beyond just roads and bridges and things like that, schools. So my biggest concern as a board member is, are we going to be able to sustain our level of service with the funding that we can get from the counties, and can the counties continue to support? So that's just a piece of information that I'll share with you so you have.
Well, I can tell you, I'm familiar with Teton County's fire department and some of the personnel there, and your EMS individuals are absolutely awesome. They do have appears to me good equipment. So I think you're in a good shape for the next year or so. EMS. Yeah, I think your county has a lot of migrant folks. Well, 2 types of migrants. You have 2 tiers, the haves and the have-nots. And so you got a really interesting public health dynamic there, because you have people that just don't have access to healthcare, and then you have other people that are really, and you have the middle roaders too. That's a really interesting county.
All right. Well, thank you very much, Dr. Curtis, again, for being here and your willingness to serve.
You bet. Appreciate your time. Thank you.
Board, we'll probably have 5 minutes, 5 or 10 minutes in between, so we'll kind of take a recess now. I should recommend that you turn your mics off. We'll just kind of go at recess. So if anybody needs a break, we'll take it now. All right, we will go ahead and get back to the business that we have. Next, we have Dr. Aaron Gardner. Thank you so much for being here with us. We very much enjoyed our visit with you last week and are again grateful for your willingness to serve on the board and to serve the community. So the process that we have, we'll have 25 minutes or so. Commissioner Mendenhall is going to ask a series of 3 questions for us to try to get to know you a little bit better and understand your position. And then I will kind of follow up with just a summation at the end and invite you to share anything at the end that you have for us.
Wonderful.
So we'll go ahead and turn it over to Commissioner Mendenhall.
Thank
you.
I'd like to have you start out by telling us a little bit about yourself and why you are interested in serving on the board of Efficacy.
Sure. My name's Aaron Gardner. I'm a pediatrician by training and also a pediatric intensive care doctor. So I did the first part of my career was hospital-based, still the majority of my career. And then the last few years have been in the outpatient space in pediatric urgent care and now pediatric home health and hospice. And throughout early in my career, had a very strong interest in public health and what you all do and what so many around the country do. That started very early in my undergraduate years. I studied sociology and had some great professors who taught a lot about what public health did to change society and to change the trajectory of the human race, particularly here in the United States. And so really from my earliest stages in training, really came to love public health. And so it's been a big part of my training as a physician and then a big part of my career. And I've just really, really enjoyed it. And what I think that I enjoy the most about it is being able to change the world and to really make a difference. And I see that in the public health space, being able to do that on a big scale, a larger scale, a community and a state and a national scale. It's a macro version of what I feel like I get to do every day in my day job. I really enjoy looking at a challenge, a patient who presents with some symptoms and some complaints and some things that just aren't going right. Well, there's a lot of factors in that. There's a lot of physiologic factors and things that go into play, but there's also every patient I see comes with somebody else who brings them. And so there's parents and families, and then there's a school and there's social interactions, and all of that plays into what we decide to do and how we deal with this illness or injury that presents itself. And I love that. And I love dealing with it. And I, as an intensivist, I like dealing with the crisis. And I kind of liked being able to walk into a bad situation and help make it a little bit better with a team of healthcare providers who help do that. And I really see public health as that same thing. Now, I still enjoy that, but I also really enjoy trying to figure out how I can keep that from happening and how we can do things and work with a team to figure out how we can stop that or prevent that, or when it does happen, make it a little easier to manage or a little quicker to get back to normal. And I really enjoy that. And that's what I see public health as. It's just on a broader scale. It's looking at the big picture, looking at it from multiple viewpoints and figuring out a way to make a difference and to make it better. And some things can't be fixed. And some things we're just going to have to figure out the best way to mitigate and lessen the damage and make things as bearable as we can. And some things we can really make a difference and stop some bad things from happening. And when they do happen, get help get the community get back to normal as quickly as possible. So
It's a great segue to the next question. Imagine the last 18 months, this board of COVID-19,
of course,
distractions, things that happen. But there are other public health issues that continue to go on. You identify 3 top public health your experience as a resident or how
3 top public health priorities. Okay. Well, I think I'll provide some answers, and if you want a little more depth or clarity on them, I'll keep speaking. I think one of the top ones would be trust. And while that you might question whether that's a public health priority, I think it really matters. There's been no question that that trust in government, in public health in general, has been a challenge over the last 18 months. And with the data and information that we have, with things changing so rapidly, with competing interests and other issues, I think trust has become a major issue in healthcare in general, and certainly in public health. I think trust from a government or public health standpoint is like trust in a relationship standpoint between me and somebody else, between me and a patient I may take care of. I think that takes time. And if trust is lost or injured in some way, I think it takes time to redevelop that. And that takes a lot of touches, and it takes a series of interactions to regain or to build that to where we want it to be, so that when information is shared, when things are passed down, that it can be taken and believed, and that when things are wrong, when circumstances and evidence that later comes up and says, yeah, this probably wasn't the best decision, or this may not have been the right way to do this. I think if the trust is there, then we can still move forward, because the intention was good, the motives were pure, and maybe it could have been done a little differently, maybe it could have been a little better, but the intention was right, and we're going to keep moving forward, and we're going to keep trying to do the right thing to do best by those we serve. And so I think trust is an important one. I think it's a big priority, and certainly it applies to the last 18 months and the biggest challenges we've faced. But I think it applies to everything else. I think it applies to the broader scope of public health, and the from vaccinations of all sorts to safety measures, to the opiate crisis, to clean water and safe food. I think all of those things matter, and so I think trust is important to maintain, to strengthen, and to nurture when we do have it. So I think that's certainly number one. Other ones that I would include would be public health preparedness, and as you've seen from my resume, this is certainly a passion of mine and a strong interest of mine. But I just feel that it overlaps and influences so much of what we do, and that is this is the piece to really look ahead, to anticipate the things that could happen and might happen and may never happen, but still could happen. And to really look at those things and look at what those implications might be. As I'm sure is on the agenda today and being discussed, and with the latest announcement from the state, the crisis standards of care have been enacted across the state. As I listened to and participated in that call yesterday with the state disaster medical advisory committee, lots of good people doing good work and doing the very best they can, and making good progress. But one of my first thoughts, as we wrapped up that call, was it's too late. It's too late for some of these things. Some of the operationalization of the crisis standards of care, we could have done more. We should have done more. And that is not to point fingers at anybody. I am part of that group. But we can do more. We could have talked about this more and early on. And a lot of it comes down to the competing issues of the day and funding and all of those things. But right now we're faced with trying to operationalize a very complex thing that most of us have never encountered in our entire careers. And we're trying to talk about it and operationalize it with the very same people who are at the bedside trying to make these decisions and create these triage committees and do this. And we just don't even have time to get together to do that. We're so busy and the hospitals are overloaded and we're surging right now. And we could have, possibly we should have dealt with this before and trained it and practiced it and prepared to make some of these really hard decisions that are going to face us in the days and weeks and months ahead. And again, I don't want to convey that, point any fingers, but only use that as a very relevant and current example of there are more things like this. There are more things like this that we can influence, and we can say, hey, what's going to happen to our healthcare system if the grid goes down, if you lose the internet and electricity for 5 days in southeastern Idaho? What's that going to do to our healthcare system? And how are we, the people who live in these 7 counties, how are we going to deal with that? I think there's some room for us to be better prepared for those things. And I think the effort that we put into preparing for those things will trickle down and affect every single day and make every day a little better. If we've had those discussions, made some of those relationships, formed some of those agreements and guidance documents, and just made some plans and tested some of those, that it's going to make us better day to day. It's going to make us better in our day-to-day interactions in the health space and in the healthcare systems that we interact with every day. I think there's room for us to keep preparing and being better, and I think it makes us better every day. So preparedness. Second.
Actually, partially answered the question. We did not know.
Sure.
How did it say, well, this board, we have Board of Health, East Idaho Health, and it's just all accounts.
Right.
Also, community leaders. And question comes, this is going to be healthcare that we're not to us. You're the physician on us, the Board of Health direction. Also, as community leaders, how are we this process? Like you said, we may be good at that.
Right, but
can you expand on that at all?
Right. Yeah. Oh, that's a great question. That's a tough question, but it's an important question. And I think my first answer to that, if this is asked of me, it would to be respond with a bunch of questions to really make sure. And this is, I've watched you all do this over the last 18 months, ask and ask and ask a lot of questions to understand what the situation is here for us. And I think that's important. I think that's an important part of crisis standards of care, is to really understand what the nature of our situation is, because while certainly crisis standards of care has been implemented across the state, and I agree with that and feel that's important, that it isn't something that's done willy-nilly in small locations or small regions or cities. I certainly agree with that, but I'd ask a lot of questions. Talk to the people that you do talk to, and that questions are asked of the hospitals, and understand the capabilities, the current capabilities, the current restrictions and limitations, and then really work to understand what the resources available are. And that's where the work that's been done in healthcare coalitions and other relationships really comes to bear. Where can we pop off? Where can we look to do things that have never been done before, that are a little different, but where are the surgical centers that we could put a patient in? There's oxygen on that wall. There's suction on that wall. There's a bed sitting there. If we got a nurse and we got a few providers available, we could take care of patients in this plastic surgery surgical center, or this orthopedic surgical center. Really work to understand what are the resources available in the communities that we live in. My first response would be to ask a whole lot of questions about that and to really understand. And then I think the second piece comes back to the answer to my last question, is trust. This is going to challenge the most trusting relationships, because this is not something that we as American citizens have had to encounter, at least on a large scale. Certainly small communities, Louisiana and other pockets of the country. We saw it early in COVID in New York City, and others have experienced this to some degree, but at large, we have not experienced this. And it is a change. It is a major change. It is something we are used to getting, and now we are not going to get it. And people who would have otherwise lived may not live. And that's going to take some communication to maintain trust. And I think it's going to take a lot of communication, a lot of education, a lot of what does it mean to ration healthcare, and how are those decisions made with as much transparency as is possible, to say these are the experts, these are the people who have the most experience in this, these are the ones who will be reviewing these cases. This is how this communication is going to happen. This is how we're verifying that these resources don't exist at this hospital or in the community. We've made this is how we're going to confirm that there isn't resources elsewhere in the state. A 2-hour ambulance ride isn't going to solve this problem. And this is how we're going to make the decision. And outline that, and thankfully the state has made great efforts over the last 18 months to put together some of that guidance and some of that. But again, now is when the rubber hits the road and we operationalize that. And that's a real challenge, because there are dozens and dozens, if not hundreds or thousands of individual circumstances and little nuances that we would need to talk about and understand. And again, it's not the purpose of the board to triage those patients, but to provide the guidance, the oversight, and I think probably most importantly, the clarity and the communication that says, yeah, we know this is awful. Anytime I've discussed crisis standards of care, and I've presented on it or discussed it or worked through workshops with it, the first thing that comes to my mind, and usually the first words are out of my mouth, are, this is awful, this is a disaster, and this is never going to feel good. We're never going to walk out of a crisis standards of care meeting or discussion and say, yeah, we nailed it, this feels great, we're saving people everywhere. The hope certainly is that we will save some people by implementing crisis standards of care. That's the only reason that we would ever do it. But it's certainly going to not feel good. It's going to be gut wrenching from the very beginning. And that's a concern too. We're going to, with this announcement today, we are going to be asking healthcare providers and administrators all over the state to make life and death decisions that we go, well, they do that every day to some degree in our standard of care that is very high, arguably one of the world's best. And now we're going to ask them to make decisions that people aren't going to survive, and that in any other day they would, and that's going to take a heavy toll on the healthcare system. We've seen that happen across the country, and in pockets before, but that's going to be a major issue. So to long answer to your short question, but there's a lot to it, and I think it would require, much like the last 18 months, a lot of discussion and more frequent meetings to really make sure this is communicated, and for us to again look to the future a little bit and say, all right, we know we've got these healthcare systems in our health district that are struggling with these decisions and making these decisions and working through this. What are we going to do, or how can we influence? How can we help make sure that we're going to be resilient, that we are going to get through this, and that we're not going to lose a big chunk of our workforce after this, and that we aren't going to see suicide rates go up in healthcare providers. What can we do to support that and to garner community support for it, that we can really support each other through this really, really difficult time.
All right, thank you again, Dr. Gardner. We know your time is extremely valuable and short, especially now. And so we appreciate you sharing some of it with you this morning, or sharing with us. I guess I would just offer, in summation, is there anything that you would like to add? We've got a lot of great applicants, but what would you like to add that would help us understand a little bit more of what you would bring to the board?
Sure. Well, I've appreciated the time to talk with you, and I've appreciated the time to think about this a little bit, and to think about what my role may be in this setting like this, and what I might contribute. I'm particularly grateful for the people in my life and in my world that contribute and that make a difference. I'm grateful for my the coaches that coach my kids in football and lacrosse. I can't do it. I was never good at it. Was never meant to be. Just not in me. And I'm grateful for PTO presidents and people who are engaged in school reading programs and things like that. That's just it's not my space. But this is my space, and this is something that I felt has been important to me for a long time, for my entire professional career, and I feel it, and I feel very committed to this cause of doing everything we can to keep people healthy and safe, and while preserving their liberties and agency. But I feel really committed to this, and I find immense satisfaction in working with good people, and in working with good people for a good cause, and that's what I feel this is. It's very clear to me that you do what you do because you love the communities and you love the people that you serve. I drove in the parking lot, and I can tell that nobody's getting rich off of their service in the Board of Health, and probably not in any of your community service. And we do it for a higher cause. There's higher cause to this. There's more important things and more important accomplishment and satisfaction that comes from this kind of service. And I've appreciated the chance to think about that a little bit. And I'm not bored, and I'm not looking for something to do, but I do care about this, and I care about what the health department is doing and what our communities are facing right now. And I think I have something that I can contribute. Certainly not something, a flag I would want to carry by myself, but surrounded with good people. I really enjoy that and appreciate the good work you've done, the amazing work you've done over the last 18 months and long before that, but certainly in the spotlight for the last little while. I've appreciated that good work and grateful for the chance to talk with you today.
All right. Well, thank you again very much. The process is we have 2 more physicians to get to know. And then afterwards, we're going to try to make a decision today. No guarantees, but we're going to try today. And then I'm sure our director will let you know later today what the process, where we are at in that process. So again, thank you.
Thank you.
Oh, so one question, Commissioner Shenton.
My observation was trust into.
Okay.
All right.
All right.
Thank you, Commissioner.
Thank you.
Thanks, Dr. Gardner. Okay, we have reconvened as the board here together, and we have with us now Dr. Joshua Stringham. So thank you, Doctor, for being here with us again today. We know how valuable your time is and how busy you are. We really enjoyed our visit with you last week, and are grateful that you were willing to come back and allow the entire board to get to know you. So the way the process will work, we've got about 25 minutes, and we're going to ask Commissioner Mendenhall if he would ask just 3 prepared questions that we have for you. And then at the end, we'll give you a chance to kind of summarize or add anything that you may have left out or wanted to include. So again, thank you, and I'll turn it to Commissioner Mendenhall.
Dr. Stringham, this is the Board of Health. So we need to have you tell us about yourself, why you're interested in serving on the board.
Yeah, absolutely. My interest in public health kind of started in residency. In Duke University, they had an opportunity as a resident. Even though we had a crazy schedule doing 60 to 80 hours a week, there was an opportunity to go up actually into the university and work with the Masters in Public Health program. And as a resident, you were able to go through the whole complete program. Because of the stipulations of our residency, we weren't able to actually get a master's in public health, but they gave us a certificate in public health, and really just opened my eyes up to truly the effect and the broadness of public health and what you can do. I am very interested in our society and both the amount of money that we spend on public health versus the outcomes in our actual health outcomes. There is a huge disparity between those two data points. And I think that we as a public have an opportunity and really a responsibility to stand up and do something about that. And I think this is a great opportunity and a good place to do that. And a little bit more about myself. I've been in private practice, full spectrum practice at an FQHC, a federally qualified health center, which is working with HRSA, working with public health. I mean, a large portion of what I do on a day-to-day basis is a public health in the community of Idaho Falls. We also have a clinic in Rigby, in Roberts, and in a clinic in Blackfoot, and just assessing the health of our community, migrant worker community, underserved, and everyone in general. And that really gives me an opportunity to see the public and also help them. As a broad spectrum, I'm a family physician, board certified family physician, and I do everything from birth to death. So I see patients. I actually am certified as an OB physician to deliver. So I deliver patients at ERMAC and do newborn exams all the way up until geriatrics, and do in conjunction with the hospice individual working with patients that are going through the death process. So if you would ask who would be qualified to do public health, someone that has that broad experience definitely would be a benefit.
Second question. As you can imagine, COVID-19 is taking up the majority of our time. But there are other issues that are covered by this. Given the breadth of experience, could you pick the top 3 public health issues and your experience that you've had?
Yeah, and COVID-19 is definitely a hot topic. And it does bring up, sadly, a lot of emotional response. And so that takes up a large portion of our time right now. And sadly, the media coverage has decreased when the pandemic has actually significantly increased. I see patients in the hospital every day through the residency program, I'm also associated with the family medicine residency program. And yeah, we're still definitely in a pandemic. The other topics that are really near and dear to my heart, the WIC program would be a very strong place that I would like to spend time in. Also, something that I have a passion for is preventative health. The US system for healthcare does a great job in reactivity. Our cardiac stints, our different surgeries do a great job with reactivity. But I think we struggle as a nation and as a community in proactivity and finding ways to prevent disease. And I have a lot of dedicated a lot of time and effort in helping my patients learn how to prevent disease. So I would really like to see the Board of Health in general work with the community on how can we make our community healthier. Not how can we react to disease process, but how can we make you healthy so you don't need to go into the hospital as much. You don't need to go to your physician as much. I know that sounds funny, right? That's my job and that's how I get money, but I would rather go out of business to have my population more healthy. So I have just kind of summing up, I have a special love in my heart for children. I actually have 6 kids, and so I have a special love in my heart for children and pregnant individuals, and then moving that over into prevention would probably be the third.
Care that we're used to, we as a public, is going to be different. Crisis standards of care is to the state. You for the physician, the Board of Health, for us non-medical people, staff, what would your guidance be to us as a board and community?
So I think the worst thing that we could do as leaders is sound an alarm that actually brings the inappropriate response of alarm. And in the other, that exact statement, flipping that on its side and saying, we as a public should sound an alarm in an appropriate way. We are still in the pandemic. I am not in the business of manipulating my patients, my community, by using fear as a promoter to get vaccinated or do other things. But I am very pro at doing what you can, doing your part. And I do believe that in most individuals, vaccines can be very beneficial. I'm not a fan of blanket statements and saying, and just pushing out these large blanket statements, but using this breadth of knowledge that all of you have that we can make intelligent decisions that are level-headed and appropriately sound an alarm. There is a huge pandemic still going on. Do we still need to work and live our lives? Absolutely. But we need to realize that it's not gone away. We have patients that, or as providers, we have to make decisions of maybe ICU care or not ICU care, where regularly they would go to the ICU. And that is, as much as the media says this and that, that is a truth that we have to deal with right now. The one benefit that I would bring to giving you guys that knowledge is I'm a working physician, and I work in the hospital currently. I do hospital work with the residents and outpatient work. So I get kind of the both lines of thought. And I would really kind of, to sum it up, want to sound the appropriate alarm and asking people and pleading with people and really helping them, to educating them that part of what your duty is to be vaccinated where it's appropriate. I think that's very important.
All right, thank you. So we do have a little bit of time. Are there questions from the board that maybe you'd feel like you didn't get answered that you would like to expound on, Dr. Stringham to expound on? Okay, I'm really seeing none. So Dr. Stringham, do you have any questions for us? Again, I know we answered most of them last week. Or is there something else that you want to expound on? As you know, we've got 4 wonderful physicians that we're interviewing today, all of them highly qualified. I hope you can understand the difficult decision that we have to narrow it down to one. But is there one thing that would stand out that would help us understand how you would be of great benefit to the board beyond what you've said?
Yeah, I just wanted to make a comment about what you said. I am so excited that you guys have a hard decision to make. This is a win-win for me. I'm here, I'm in public health, I'm in the community health center, and this is what I'm going to do on a day-to-day basis. And I'm excited, whether it's me or the other 3 individuals. They're wonderful people, and I'm excited to work with any of them. And you guys have a hard decision, but it's a win-win in my part. I'm excited about that. I think one thing I would bring is passion. I love community health. There's lots of things to be said about a community, a federally qualified health system. Those people that you see in that area go there for a reason. And they go there because they feel like the mission statement fits their own personality and fits their own personal mission statement, which is to serve the underserved and the community at large. And I feel like that passion is very applicable to the public health in general, not necessarily focusing on one demographic, but really trying to focus on the community at large. So I'm already here, I'm serving, I love it. So I would bring passion and maybe a breadth of knowledge from multiple different avenues, not just one siloed specialty.
Okay. Again, thank you very much. We really do appreciate your willingness to serve the community in this way, and we appreciate all that you're already doing. I know you serve a lot of people that need that service, and so again, thank you. And we'll go ahead and conclude with that.
Thank you.
Oh, I'm sorry, Dr. Stringham. I failed to say, so at the conclusion of our interviews today, we're going to meet and try to come to a decision today. I'm hopeful that we'll be able to do that. And so you should hear from our director probably later today to at least where we're at in that process.
Perfect.
All right. Thank you.
Thank you.
Okay, we are just a few minutes before our agenda, but we have everyone here. So we'll go ahead and get started. And next we have Dr. Pamela Denson. Thank you again for being here. We very much enjoyed our visit with you last week.
Okay.
And it was good to get to know you, and we appreciate you coming back. We know how valuable your time is, but to be here with us so the entire board can get to know you and we can follow up with a few questions. We have some great physicians here today, and all of you are just so qualified, and we appreciate your willingness to serve the community in this way. So the process we're going to take is we'll have about 25 minutes.
Okay.
And Commissioner Mendenhall has 3 questions that we've prepared that he is going to ask you, and then we'll allow you to kind of summarize at the end.
All right.
So go ahead, Commissioner.
Okay, excellent. So my name is Pamela Denson. I'm an OBGYN. I did my medical school at the University of Florida, and then I did my training at UT Southwestern in Dallas, Texas. I was in private practice in Missouri for 2 years after that.
Dr. Denson, I'm sorry to interrupt you. In this big room, would you speak a little bit louder?
Okay, sorry. Maybe I'm not like straight at the microphone. So I was in private practice in Missouri for 2 years, and then I've been in Idaho Falls as an OBGYN since 2014. And so I do deliveries and surgeries at all 3 of our local hospitals here in Idaho Falls. And that's a little bit about me. My husband's actually an OBGYN as well. We are in the same practice together, and we have a 5-year-old little boy. So it's a little bit about me. As far as why I wanted this position, I mean, I think with the pandemic, it was definitely an eye opener as far as, the implications that public health decisions have, not only just preventing disease, but the overall long-term implications that it has on my patients and their mental health, everything from their overall health and not just necessarily this. So I wanted to be able to help and participate and serve the community to the best of my ability. Is this better? Oh, that's way better.
It's way better.
Okay, sorry about that. So I wanted to just be able to have the opportunity to serve the community and be able to provide you with the best resources possible. I think one of the hardest things for a non-medical professional is being able to look through the data, read through the data, and provide you with the most evidence-based, objective information out there to make the important public health decisions that you have to do for the community. So I feel like my role would really be to be able to interpret, look through that, and provide you with the information that you need. I also feel like as an OBGYN, I'm kind of in a unique position, with the WIC program, with a lot of the stuff that you do for preventing STDs and pregnancy and that sort of thing. I feel like I'm kind of in a unique position to really be able to help with that as much as possible. I mean, more than 50% of my practice is just, helping pregnant women and also doing their deliveries and taking care of them afterwards. So.
That is a good segue into our second question.
Okay.
As you can imagine, as you said, non-medical, COVID-19 has occupied the past 18 months, majority of this court's time.
Mm-hmm.
All of everything's happened. But with your experience, could you pick 3 top public health concerns and how your experience helps address them?
So directly related to COVID?
No, sorry, I probably used that a little bit. Just your top, what you mentioned with STDs.
Yeah, absolutely.
Public health concern, your top 3 in your medical experience and how you experience it.
Okay. And I mean, I think the number one thing is, I do a lot of primary care. I do a lot of annuals, just seeing my regular patients just for their annual, physicals and that sort of thing. I think really encouraging preventative medicine is one of the most important things we can do. One of the things we've noticed with COVID-19 is that the people that are at the highest risk of getting sick are the ones that are already not very healthy. One of the biggest risk factors is obesity. So I think addressing and, educating, encouraging the public to be as healthy as possible would really help improve our outcomes long term. I think that's one of the most important things. I think the second important thing that I can think of is, I think especially with COVID, I think that the most important thing we can do for our community and our patients in general is really encourage early treatment. I do that with my patients now. If they're sick, we're trying to do everything we can to prevent you from going into the hospital and utilize resources. So whether it be COVID or whether it be something else, like for example, STDs can cause a lot of long-term repercussions. So if we can have you come in and get tested and get treated early, we can prevent a lot of the long-term implications of infertility and that sort of thing associated with it. So, preventative medicine, early treatment, whatever the issue may be, and how to get that information out there to the public and the resources that we have plenty of resources at our disposal to prevent you from being hospitalized, especially with COVID, but other things as well. There's monoclonal antibody treatment out there. A lot of patients are not aware of that. So how do we get that information out there into the community that contact your primary care doctor early? Don't just sit there at home and be sick. Come to us sooner so that we can get these resources to you and also prevent our hospitals from being overburdened. So those are some of the top issues I see at hand right now.
That does take us into, as you described that, we heard reports from hospital representatives earlier today, and it's the stress and strains on hospital resources, staff, and the care that we come to expect might look a little bit different in the future, and crisis standards of care at the state. If you were the physician with these non-medical people, us, with the physician going forward, what would you advise us? What would you tell us? We also represent communities.
Right.
What would you tell the board as a board of health and also the communities that we represent?
I would say two things. First, let's try to keep as many people out of the hospitals as possible. Early treatment, I think, is, very important for that reason. But then also let's explore really what this is. I mean, it's not necessarily just, a bed shortage, it's a staffed bed shortage. And that means that we don't have enough nurses staffing those beds. So what can we do to help with that? What can we help the hospitals do to make sure that they have enough staff on board? I think that there are enough actual physical beds in the hospital. So how can we address that? I think another thing that might be interesting too would be, let's get data out there on how the different hospitals actually manage COVID. Like what are the mortality rates at those hospitals and what are the hospital's length of stays? Like, do you have somebody that's doing a better job than the others? And if we do, and we find that information out, let's share that information so that the hospitals can decrease these hospital stays and have more beds available. The final thing is, and this is what I've seen because I'm at both hospitals, well, all three, but I'm at both hospitals all the time. There's definitely a bed shortage, but a lot of these hospitals are taking, and I'm all for doing the best that we can for every human in this country, but there's a lot of patients from the state of Washington and the state of California. They even admitted somebody from Texas. So, what does that mean for our community? I'm sorry, but I think our community members come first. We need to make sure that there's enough beds for, the people of Eastern Idaho. Then we need to make sure that there's enough beds for the state of Idaho before we go accepting patients from other states. I know some people probably wouldn't agree with me on that, but I feel like it's very important that the people of our community come first. We pay taxes here, we live here.
All right. Yes, you did. Very well. Thank you very much. Is there any question that a board member has that they need a little more information on? One of the questions? Okay, you were very complete. And again, we really appreciate you being here. Is there anything that you would like to add that you haven't had a chance to say?
No, I mean, I think I asked them my questions last time and I feel very comfortable with that. So thank you for giving me this opportunity. All I have really.
All right. Well, thank you very much. It really, we are all, I think I can speak for the board, overwhelmed and grateful that we have such a group of physicians to pick from, and that so many of you are willing to serve in this capacity. It is a critical position on the board, and so we are thankful that you're willing to do that. We will meet today to kind of try to make a decision. But one way or another, our director will get in touch with you later today to let you know where we're at in that. So thank you for coming in.
Thank you so much. Okay.
All right, board members. As you can see, we have some very great choices and a difficult decision to make. But make it we will, because we are only allowed to have one addition to our board, and and that person needs to be a physician, and so we've got some great applicants. I would recommend now that to discuss personnel, that we go into executive session. So if someone's willing, I would entertain that motion. Okay, thank you. And please cite the code.
Be helpful. I need the code.
So it's, the code is 74-206A.
Code for this executive session is 74-206A.
That's correct. And the statute does stipulate that we can enter into executive session for these deliberations. To do so, we need a motion with the code addressed.
Second it.
Okay, the second is by Commissioner Young. And it requires a 2/3 majority of a roll call vote. So I'll go ahead and call that roll now. All in favor, Commissioner Mendenhall.
Yes.
Commissioner Young.
Yes.
Bill Lake. Yes. Commissioner Shenton.
Yes.
Commissioner Dance.
Yes.
And Commissioner Mattson.
Yes.
Okay, we have a unanimous decision to enter into a executive session to deliberate about our position. So we are going to go ahead and pause the public meeting at this time. We will leave it open. It will continue. But we will be in another room deliberating under executive session of 206. As soon as we feel like we come to a consensus of the board members, we will return to this room and again begin the public meeting. And we will hopefully have a motion to decision. So, thank you. Let's go ahead and reset the room that Okay, we are ready to reconvene in open session. Want to thank, publicly thank physicians. We are grateful and grateful. Said over and over, all of be a great asset to us. Great resource. Decision to make, so.
Mr. Chair, I'd make a motion. I make a motion that we nominate Dr. Gardner to be our physician on our public health board.
It's Commissioner Shenton. I'll second that motion.
All in favor, say aye.
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 Any opposed? Right now, you would notify Dr. Gardner and please notify all of them. Please express to our sincere thanks. All right. With that said, we'll go ahead and move on.
Yeah, we can move on.
Okay.
This one?
Just so y'all know, we're trying to get better technology to, if we have to continue meetings in this fashion, so. All right, I do have some staffing updates. Over the last few months, as things started to settle down, some of our temporary staff that had been working in James's division, helping with the contact tracing and disease investigation, many of those temporary staff left us, but we are quickly trying to refill many positions as case counts have increased over the last month in our district. In addition, Amy's trying to fill several positions in her division as we gear up for potential booster shots in the very, very near future. And I don't know if this is okay for me to say right here, but we did hear while we've been in this meeting that the CDC's Advisory Committee on Immunization Practices is not scheduled to meet now until Wednesday and Thursday of next week. So we will not have any movement on booster shots for Pfizer until at least next Wednesday. So we were trying to get more nurses to help us, more clerical staff. We have called up members from the Medical Reserve Corps again. Unfortunately, we're having some that took the summer off that have been very dedicated volunteers that are working to get back with us to help with this next round of vaccines. One in our environmental health program, you've heard this before, but things are going gangbusters, especially in our septic program and our land development programs. And we are currently looking to hire another environmental health specialist as well as a clerical staff to assist in that program. And then very sad to share a update that Angie Harwood, our public health administrator over our nutrition division, has accepted a different position and will be leaving us at the end of the month. So we're currently recruiting for a new public health division administrator. So those are the primary updates that I wanted to share.
Angie, thank you. We have all been on this board with this commitment, passion, desire to serve, given the way that you have. So thank you very much. You will be missed.
Is it okay I share your new role? So she is staying with public health. She's just taking a state level job. So we'll be able to still work with her in her state role, but it is definitely a huge loss for Eastern Idaho Public Health. So thank you, Angie. Just one more thing that, okay. The last item on the agenda is a septic system enforcement action hearing. And Kelly did report at our last meeting some enforcement actions that we're moving forward. There's been no progress made on it with the individual, and so we are moving forward to have a hearing. That is within the authority of the board to have a hearing and determine the next steps, and to determine if no compliance is gained with the septic rules, in the next weeks leading up to the hearing, the next steps that the board would choose to take, including legal proceedings. So that hearing has been set for October 14th. No, on the agenda it says 9 o'clock, but the official hearing notice that I received is 10 a.m. And so I am proposing, Mr. Chairman, that we actually have a board meeting that day. We had not scheduled, did not have one previously scheduled. We could keep it, I believe, to a few hours, but to include that hearing as well as some other public health topics. It's Thursday, October 14.
If it is difficult, we will go ahead and be here in person. If it is difficult for any of you, especially if you have to travel, we will have the Zoom link on. Have the person if possible. We're going to start at 10.
I think let's start at 10. That can just be our first item of business,
Okay.
and then proceed after that. Right.
Okay. All right, so 10 o'clock, October 14th. They have that second issue along with other.
But that'll probably be in here then.
Yeah. Anything else? All right, with that, thank you all for your service today and for your time. And I'll go ahead and call this meeting to close. Thank you.
Thank you, everyone.